Hello, and thank you for joining us today. My name is Dr. Amy Rolfsen. I'm a naturopathic doctor and medical educator based out of British Columbia, Canada. I'm also part of the clinical team here at Diagnostic Solutions Lab. So today we're going to talk about inflammatory bowel disease and how you can use advanced functional testing to individualize your treatment plans and get better outcomes for your patients. Here at Diagnostic Solutions Lab, we are experts in advanced laboratory testing. We have a number of different tests. Our flagship test that I'll be talking about today is the GI map, which is a quantitative PCR test that looks at microbiome, good and bad organisms, as well as an intestinal health panel. So it's a comprehensive stool analysis. I'll also be talking about a few other of our tests that you can use to dive even deeper with your patient. Beyond lab testing, we also know that a test is only as good as the interpretation. So we offer advanced interpretation through our clinical team. So the agenda today is going to be very simple. I'm going to do a brief overview about inflammatory bowel disease. Instead of focusing on the differences in what you might find in these conditions, I'm going to go deeper and talk about specific immune changes you might see, neurological changes you might see, and then differences at the tissue level, as well as microbiome changes. And everything I'm going to talk about today is going to be highly clinical and things you might want to use to tailor your treatment plan to be more specific for your patient. I'm also going to go over some of our functional labs, some examples of what you might see in inflammatory bowel disease, and how you can interpret that for your patients. I'm going to talk a bit about conventional treatment, and then I'll go into some evidence-based natural therapies, as well as nutritional therapies. So let's get started with talking about inflammatory bowel disease. Inflammatory bowel disease consists of two major conditions, Crohn's disease and ulcerative colitis. There's a third subset of conditions called microscopic colitis that sometimes, but not always, involve inflammation of the bowel. So for this reason, microscopic colitis isn't considered by everyone to be an inflammatory bowel disease. I won't really be talking about it today, although it is a condition that deserves a lot of attention. Today's topic is going to be Crohn's disease and ulcerative colitis. So both of these conditions are chronic, both are immune mediated. Both primarily involve inflammation of the intestines. Both involve periods of a flare or exacerbation and then remission where your symptoms are much, much better. And both involve other conditions that are very closely related, as well as some negative outcomes that we can work in our practices to help our patients avoid. So you see there are a lot of similarities between these two conditions. There are also some differences. So for the development, we need to have genetic factors that will predispose a person to inflammatory bowel disease. We need to have environmental factors. Here's a small list of what may be considered environmental factors, things like diet, microbiome, immune changes. And now let's get to the differences. So Crohn's disease. So this inflammation involves the entire wall, the entire thickness of the GI tract, segmental lesions, which means that you'll have what's called skip lesions. You'll have disease in one area and then healthy bowel, and then disease in another area and healthy bowel. And it can be found anywhere throughout the GI tract. I've listed the symptoms here: diarrhea, abdominal pain, anemia, fever, weight loss, very similar to the symptoms of ulcerative colitis, which involves inflammation of just the mucosal layer. Instead of having discontinuous lesions or skip lesions, we've got continuous, and it's usually starting at the rectum, working its way upwards. So it'll start at the bottom, you'll see it in one continuous disease state, working its way upwards. And then very, very similar symptoms to Crohn's disease. So let's talk a little bit about the immunology or the immune changes. I won't get too deep into this. I want to keep this as simple as possible, but just highlighting that this is an area where you will want to look for your patients to get your treatment more individualized, more fine-tuned to what they're actually going through. So you will see different immune changes, different cytokines, different immune cells involved in ulcerative colitis versus Crohn's disease. If you look deep enough in lab testing, you will see differences from person to person as well, even with the same condition. So two patients with ulcerative colitis will have very different immunology. And this explains why some people respond to some therapies, some people respond to others, some people don't seem to respond to any and really, really struggle. And then within the same person, your immune changes, your immunology will also be dynamic over time. So at the point that your immune-mediated condition, say your ulcerative colitis, is triggered, the first event, that's going to be a very different immune picture than you'll see 10 to 15 years down the road when you're more chronic. When you're flared, you'll see different immunology than when you are in remission. So it can get very complex, and there is high value in looking at the cytokines and looking at the specific immunology of your patient if you want to get fine-tuned, and this especially applies to people that are non-responders to traditional therapy. An often overlooked factor in inflammatory bowel disease is oxidative stress. So this is secondary to inflammation. Reactive oxygen species are highly volatile and will damage tissue, damage the microbiome, and perpetuate inflammation. They are products of the circulating immune cells that are involved in the inflammatory state. They are very damaging to beneficial bacteria. And this is because a lot of our beneficial bacteria, I would say most in the colon, are what's called obligate anaerobes, meaning that they are obligated or have to be in an anaerobic or no oxygen environment. So oxygen is actually toxic to these bacteria. And as we clear out our obligate anaerobes or our good anti-inflammatory bacteria, what is called facultative anaerobes will move in. And these are organisms that prefer an anaerobic environment, but they can make do. They can handle it, especially if there is a space left behind by other bacteria. And many of these facultative anaerobes are more inflammatory, many are gram-negative, and so you'll see this microbiome skewing towards a pro-inflammatory, partially as a result of oxidative stress and reactive oxygen species. You'll also see the reactive oxygen species upregulating your immune responses, perpetuating more inflammation, as well as increasing the mucosal inflammation at the level of the mucosa and damaging our gut lining. Now, barrier dysfunction is a huge factor as well, and an area where we can really target people's health from a functional perspective. I'm going to keep this very, very simple. So our GI barrier, or gastrointestinal barrier, is both a physical and an antimicrobial barrier. This is very protective for our immune function and is absolutely necessary for maintaining an anti-inflammatory state in the gut, as well as a healthy microbiome. So with inflammatory bowel disease, we see a loss of mucosa. We see increased permeability between the cells, and we see a decline in the health of our epithelial cells, or the cells lining our GI tract. We see a loss of the oxygen gradient, and so what we would generally see in the center of our large intestine, we would have an anaerobic environment. And then as we move through the mucosal layer, we would have more and more and more oxygen. And then we get to the cellular layer down here where we have aerobic respiration. And so what you'll see in inflammatory bowel disease is the increase in oxygen here in the lumen and a decrease in oxygen at the cellular level. So a dysfunctional oxygen gradient, which again will skew towards a more inflammatory microbiome and will lead to poorer health of the epithelial cells. So we really need that barrier function to be intact, healthy epithelial cells, healthy mucosal production to have good gastrointestinal health. When we start talking about nervous system involvement with inflammatory bowel disease, this can get highly complicated. We're talking about multiple strains of bidirectional or two-way communication between the nervous system and the gut. So this is saying that the health and state of our nervous system will affect our gut health, and the state of our gut will affect the health of our nervous system. Now, I could talk about this for a full hour, but I'm going to keep this extremely simple, potentially oversimplified, but this is for the sake of getting it in the presentation. And so let's get started here. So stress can promote immune dysregulation. So this will promote inflammation and promote the cells that are more inflammatory in the gut. Stress will also affect the barrier permeability. So what you see as classic leaky gut can be from stress. Stress can alter your microbiome through a number of different mechanisms, with an ultimate shift towards our pro-inflammatory organisms and away from our anti-inflammatory organisms and our really beneficial short-chain fatty acid producing organisms. With stress, you will also have inhibition of your parasympathetic or rest and digest nervous system, and the vagus nerve is the main cranial nerve involved with this system. The vagus nerve is highly anti-inflammatory in the GI tract. So inhibition of the vagus nerve removes that anti-inflammatory mechanism by which it can be protective. Now, people with inflammatory bowel disease have higher rates of mental health concerns than the general population. What you see is a higher rate of anxiety, higher rate of depression, a higher rate of insomnia by a lot. And part of this is neural inflammation. So inflammation in the GI tract can transmit to the brain as inflammation in the brain. And that can be highly damaging and can really change a person's mental state. So we will see that the incidence of anxiety, depression, and insomnia are worse when people are flared versus when they're feeling better, when they're in symptomatic or endoscopic remission. Now, moving on to some other inflammatory bowel disease specific states, I want to talk a little bit more about the microbiome and inflammatory bowel disease. So we've talked a little bit about how some of the aspects of IBD can affect our inflammatory versus our anti-inflammatory microbiome. Now, over and over again, there has been the signature found within the microbiome in inflammatory bowel disease. So we'll see very reliably a decrease in diversity. So the decrease in the different types of organisms that are present. We'll see a decrease in the anti-inflammatory Firmicutes phylum. We'll see an increase in Proteobacter, which are gram-negative, generally quite inflammatory bacteria. And then we'll see an increase in instability. So one of our markers of health of the microbiome is stability over time. So if we see this variable microbiome, that is a sign of poor gut health. So over and over we see this pattern, and then it gets a little bit more specific as well. So we see a lot of overgrowth of less beneficial, more inflammatory organisms. In this orange box, I've highlighted a few organisms that are classic as triggers of inflammatory bowel disease. So I mentioned earlier that environmental factors are necessary for the onset of inflammatory bowel disease. A bacterial infection can be one of those triggers. And then beyond that, the other organisms here are commonly found as overgrowth patterns in inflammatory bowel disease, either at onset of condition or years into the condition, either flared or in remission. We will often see overgrowth of these organisms. And all of these organisms will perpetuate low-grade inflammation, which can keep disease states higher. Compounded onto that overgrowth of less beneficial bacteria, we also see a deficiency of the commensal or beneficial organisms. Now, we spoke about this a few minutes ago. I don't think I need to belabor this point, but here are the common deficiencies we will see in inflammatory bowel disease very regularly. All of these are organisms we can look to on GI map, as well as the previous slide. We highlight all of these organisms, and these are patterns that we see very frequently when reviewing GI maps for people with inflammatory bowel disease. Now let's take a look at how we can use advanced lab testing to highlight the differences between our patients and get extremely individualized with our treatment protocols. First, I want to talk about conventional lab testing. So the classic way to diagnose Crohn's disease and ulcerative colitis, first you're going to pick up on a symptom picture, and that will be through your GP, through your primary care provider. We can test blood and calprotectin in the stool, and that is a very common first step to screen for inflammatory bowel disease. If those are found to be high and a patient has enough symptoms, they will go on to get endoscopy. So this is the true diagnostic for inflammatory bowel disease. So you'll frequently have both an upper and lower endoscopy with a biopsy, and visually and with those biopsies, they will diagnose either Crohn's disease or ulcerative colitis. Sometimes you'll see pancolitis, sometimes you'll see inflammation, but you don't have a formal diagnosis. And all of these are valuable information. Sometimes the diagnosis is clear, sometimes the diagnosis is less clear, but we know that there's an inflammatory or dysfunctional state, and we can work with that. Now, a few other tests you can run to differentiate between Crohn's disease and ulcerative colitis and rule them in would be some blood antibodies. So I won't go into these deeply, but there are some blood tests as well there that are worth knowing about. Now, The goal of treatment of inflammatory bowel disease is remission and lasting remission. And there are 4 levels of remission that are worth knowing about. So the most superficial level of remission is symptomatic remission. So you have symptoms: diarrhea, often bloody diarrhea, cramping, fever, weight loss, and then you don't. And that's called symptomatic remission, is when you feel better, when you feel, okay, I don't actually currently have symptoms of my Crohn's or colitis. Now, to go 1 level deeper is going to be biomarker remission. And that is going to be things like your calprotectin, so your inflammatory marker in the stool, blood in the stool. You can look at things like CRP in your serum testing and a number of other markers. This would be where testing cytokines comes in as well, or inflammatory biomarkers. 1 level deeper from biomarker is your endoscopic remission, where when they go in with a scope, either upper or lower, and they look at the tissue, there's no longer visible evidence of disease. And then the deepest level is histological, where on scope, there will be a biopsy taken and the tissue under microscopy and at every level is in a healthy state. The cells look good. So obviously the upper level, the histologic remission, is the ideal. That's where we want to get. And it's been found that the best outcomes come with both endoscopic and histologic remission. Whereas with just symptomatic remission, we might actually have still inflammation. We might still have deeper signs of disease, but a person is feeling better. So often what I'll see in clinical practice is people will feel better, but their disease state is still ongoing. So you'll still see on scope that the tissue is damaged. Sometimes you'll still see inflammation and blood in the stool. So what we have easy access to testing is those biomarkers. It is a lot more challenging to access endoscopy and histology, but it is fairly low invasive to look at biomarkers. So what we want to know is, how well do biomarkers reflect endoscopic and histologic remission? And as it turns out, very well, especially calprotectin. So fecal calprotectin can be used, and over it has been found to reflect on histologic activity and endoscopic activity. So if your calprotectin goes from abnormal to normal, frequently the endoscopy and histology, so the endoscopy and biopsy, will go from abnormal to normal. So they reflect each other very, very well. So calprotectin can be a shorter term measure, not a replacement for repeat endoscopy, but a stopgap if you want to test calprotectin every few months while you're waiting for another scope. It can be indicative of disease remission and improvement. So now I introduce the GI map stool test. This is the flagship test at Diagnostic Solutions Lab. It is our most popular test, and this is a microbiome test. So we are using quantitative PCR technology to pick up organisms in the gut. We will pick up common dysbiosis patterns. You will see if your patient has inflammatory dysbiosis, insufficiency or not enough beneficial flora, or both. As well as that, we're looking at intestinal health markers like calprotectin and blood. We're also looking at digestive health, immune health, and some markers of barrier permeability. I use this test in every single inflammatory bowel disease patient. Anybody that comes into my office with inflammation in their gut, whether it's been diagnosed or not, can benefit from this test, and the results you will get on this test will be very helpful in your treatment. Now, a question we get a lot is, can we use this test on somebody who has a surgically altered bowel? So surgery is really, really common in inflammatory bowel disease. And my answer to that is yes, but as I said before, a test is only as good as the interpretation. So if you are running this on a patient who has a surgically altered bowel, make sure you have a very good clinical history. You know which sections are removed and the outcomes of the surgery, and then consult with somebody on our clinical team, because this does take advanced interpretation, but we can get a lot of valuable information from a stool test of somebody with an altered bowel. Now, this is a single stool sample, and let's take a look at what the results might look like. So when I interpret a GI map for a person who has inflammatory bowel disease, I don't start on page 1. I start on page 4 at the intestinal health markers. So the first thing I want to know is, does this person have active blood in the stool and active inflammation or calprotectin? So the first things I'm looking at are occult blood. And here, this is very typical of somebody who is in flared state of inflammatory bowel disease. You see blood here is over 200. And this is one of our red flag medical findings where if you see this, and this is somebody who has not gone down the diagnostic pathways, you would want to refer them out. The other thing we're looking at first that is typical of IBD is calprotectin. So calprotectin is a protein produced by neutrophils. So this is showing that we have neutrophilic infiltration, and other immune cells can also produce calprotectin. So a great deal of immune activity in the gut. So when we see high blood, when we see high calprotectin, this is absolutely classic for inflammatory bowel disease, both Crohn's and colitis. You'll also commonly see eosinophil activation protein high, and in this case, we see it over 10, which is showing that eosinophils, a different class of white blood cells, are also active in the gut. So there's a lot of inflammation going on here. In fact, you want to look at every single marker on page 4 because you'll see variations in all of these in your patients with inflammatory bowel disease. So at the top, when we assess digestion, we want to make sure our patients are digesting and absorbing as much as they can. Absorption is often limited, and so pancreatic function is crucial. We also want to look at immune function, like the secretory IgA, anti-gliadin IgA to look for a gluten reaction, and a hyperactive immune response. So when we're looking at page 4 at our biomarkers that can indicate disease activity in inflammatory bowel disease, there are a number of different presentations we'll see. So in true remission, you'll see normal blood and normal calprotectin. Often we'll see patients come in, or I will talk to clinicians that have a patient, and they say, I'm in remission at the moment. I don't have any symptoms. And we'll say, okay, let's take a look at your test. And yet we'll see high blood and high calprotectin. And this indicates that although symptoms are better, which is wonderful for the patient, wonderful for quality of life, there is still that underlying disease state that will lead to the blood and inflammation. And we do need to go deeper with our repair work and with our protocols. Another state would be a completely flared, and we'll see this a lot, where similar to the previous slide, we'll see high blood, high calprotectin. And then a fourth state that is a little bit less common than the others is when somebody comes in with symptoms of inflammatory bowel disease and a previous diagnosis, but the biomarkers are normal. So you have normal blood and normal calprotectin. And this would generally indicate that what's going on is not inflammatory bowel disease. So maybe this patient at this point in time is struggling with IBS. Maybe there's some dysbiosis that is leading to looser stools and cramping and symptoms that can mimic IBD, but it's not an actual inflammatory IBD presentation. So important to distinguish between these two by testing blood and calprotectin regularly. Once I've looked at page 4 at the intestinal health markers, then I start back at page 1 and we're looking at pathogens. So starting with bacterial pathogens here, C. diff here is one of our classic triggers for inflammatory bowel disease. And I very frequently see it here at moderate levels for people with IBD. Sometimes we'll see things like Campylobacter, but that's much less common. E. coli is a bit more common. And then Salmonella can be another trigger that we see very infrequently after that triggered state. So moving on from the pathogens, on page 2 of GI Map, we'll find our commensal organisms. These are the bacteria we want to have present and that need to be present at healthy normal levels to maintain a healthy GI tract. Now here we see something typical for IBD sufferers, which is low commensal organisms. And the most classic findings would be a low Akkermansia muciniphila, a low Faecalibacterium prausnitzii, and then in addition you may see other organisms low, like Escherichia here is highly tied to a healthy mucosal lining. So when the mucosa is damaged, often you'll see Escherichia falling low. So when I look at this, I think, okay, we need to work on some anti-inflammatories. We need some polyphenols. Maybe we supplement some organisms. Maybe we give fiber if this person is not in a flared state. And we want to bring up these beneficial organisms just as much as we want to bring down any inflammatory overgrowth organisms. Page 3 of GI Map is where we start looking at opportunistic organisms. So first we start by looking at bacteria. And looking at this is really typical for what we'll see, especially in Crohn's disease. You'll see a lot of inflammatory dysbiosis. So the organisms that are elevated here, I'm not going to highlight any individually, but many of these are pro-inflammatory, gram-negative organisms. Some are histamine producers. Some will predispose to intestinal hypersensitivity. so that increased pain perception. And many of them will promote inflammation in the gut. Now, further down on the same page, page 3 of GI map, we see more overgrowth organisms. So here, Fusobacterium is highly tied to inflammatory bowel disease, and we see it very frequently in these states. Candida overgrowth is really common in both Crohn's and colitis, and I would say more common in Crohn's disease. So looking at all these dysbiotic organisms gives us so many targets that we can help to prioritize treatment to remove any inflammatory triggers, anything that is perpetuating a flare. And so there's often a lot of targets on GI map that you can use to target treatment specifically to your patient. Now I want to show you this great test we have. It's called CytoDX, and it measures cytokines or inflammatory markers in the blood. So this is an advanced test, and it gives you an individualized inflammatory assessment. So like I said before, between individuals, you will see different immunology or different immune changes, even within the same medical condition. So this test will allow you to fine-tune that treatment, especially useful for your patients who are not responding to classic therapy. So the collection for this sample is a serum collection, so this will require a centrifuge in your office, and it also requires being shipped on dry ice. So not everyone's going to have access to this test in clinic. There are phlebotomy services where you can access this test if you really, really want to, and I would not use this in every single case, but it can be extremely useful for those cases that just really are stumping us on every level. So I'm just going to show this image again that shows the differences in immune cells between conditions. You'll see down at the bottom that the red squares are ulcerative colitis. The turquoisey blue squares are Crohn's disease. So you'll see different inflammatory markers. A lot of our conventional therapies target single inflammatory markers, things like TNF alpha. And so you may see on CytoDX that TNF alpha has gone down to 0 when using a TNF alpha inhibitor, but you might have other inflammatory markers high. So this next slide, I'm going to show you what the CytoDX looks like. So here's an example of a CytoDX result for somebody with Crohn's disease. Now you'll see here interferon gamma is high, interleukin 6, which is really classic for inflammation, is high, interleukin 12 and 17A are both high, as well as interleukin 10 and interleukin 15, classically anti-inflammatory cytokines. So sometimes you'll actually see those anti-inflammatory cytokines high in an attempt to dampen the inflammation. Now, if the pro-inflammatory cytokines are higher than the anti-inflammatory, you've got yourself a problem and you'll have some inflammation. So this is how you can fine-tune your treatment to specific inflammation. And then there's great research out there with our natural therapeutics targeting different inflammatory cytokines. Now, if you want to get next level with your assessment of your patient, I would suggest trying the Omics Metabolomic test. And this can be run as a baseline on any patient in your practice. This will give you an idea of how people's metabolisms are working. So in inflammatory bowel disease, we have a huge rate of malnutrition, which may be affecting every level in the body. So it'll affect cellular development and maintenance everywhere. So this will give you an individualized metabolic assessment, and again, helps you to fine-tune treatment to your patient. And yeah, we look at some nutrient deficiencies here, and we'll assess metabolism of things like carbohydrates, fatty acids, and proteins. A lot of protein markers on here. So this is a test that is a serum and a urine collection. Those need to be shipped frozen. And again, you'll need a centrifuge for this. I'm not going to go deep into this test. It is a highly involved test that takes a lot of interpretation, but you'll get these different areas of metabolism, and it'll show you where you are the most out of range, where you're totally normal, and where you need some work. And then you go deeper into the test and fine tune it. And it can make a huge difference clinically for people, not just for inflammatory bowel disease, but for anybody who's feeling well, anybody who's feeling unwell. It's great to get a baseline metabolic assessment. And now on this next slide, we see just a chart here of ulcerative colitis and Crohn's disease and which markers tend to be high and low. And so these are the signatures of Crohn's disease and ulcerative colitis that you might see on Omics. Again, it's a great test. I would say for every patient, you want to run a GI map, and then you can augment that with a CytoDX or an omics or both. And that is an example of how you can use our labs to fine-tune your treatment plans. Let's talk conventional treatment. So I personally believe there is a huge place for conventional treatment in the world of inflammatory bowel disease. In the functional space, a lot of practitioners are shying away from conventional treatment and recommending their patients avoid medication. And that can be of value if that's the patient goal. But in my opinion, one of the big goals in treating inflammatory bowel disease is the avoidance of end-stage results, which are things like surgical alteration of the bowel or progression to colon cancer or disease that progresses out of control. So I do think there's a place for prescriptions, and you can work within these. You can co-manage cases, but don't shy away from the use of well-chosen prescriptions. Surgery in inflammatory bowel disease, the rates are extremely high. So for Crohn's, 30 to 40%, ulcerative colitis, 20 to 30% will eventually need some form of surgery. Clinical considerations here are eventual short bowel syndrome. Every surgery may affect your nutrient status. So if you remove a part of the bowel, you remove the ability to absorb nutrients that bowel specializes in absorbing. And then your expectations for treatment may differ. So say you have a patient who only has a small intestine. They have their entire colon bypassed or removed, and your patient has chronic diarrhea. Now, the expectation for treatment or the hope for treatment might be to have normal formed bowel movements, but then when you consider that the colon is responsible for absorbing water, maybe the biomarker we're following should not be normally formed bowel movements. So maybe we're looking for other things. And so that's how, sometimes surgical alteration will change your expectation for treatment success. Now, what I find really important and often overlooked is a clinical history. So I'll talk to people and they'll say, okay, so he had some parts of his small intestine removed. And then I'll say, okay, which parts? And sometimes patients don't know, sometimes practitioners don't know. And so I'm going to urge you to take a really good clinical history around surgical alterations. So we want to know why the surgery was performed. We want to know how the recovery was, what the outcomes were. We want to know what sections of bowel were removed. And then we want to know how long ago the surgery was, among other information, but those are the absolute basics that you need to get from your patient if you want to properly treat somebody with a surgically altered bowel. And you can always refer these cases out as needed, but again, you can run a GI map on these patients and we can help interpret it. Our clinical team is well versed in all aspects of inflammatory bowel disease. Let's talk briefly about the medications that are used in inflammatory bowel disease from a conventional standpoint. I'm going to speak as if you're not a prescriber, because most of our clientele are not prescribers of inflammatory bowel disease specific medications. So most people I speak to have patients that come in after seeing gastro. So if you are a prescriber, my apologies for not aiming this directly at you, but I just want to give a brief overview of what you might see. So steroids are really, really commonly used to reduce a flare, to get people out of a severe active IBD flare. And so these are strongly anti-inflammatory and immunosuppressive. And some clinical considerations from a functional standpoint would be bone density. So if steroids are used frequently or for longer term, you want to consider bone density. And then some of the many nutrients that could be depleted here would be calcium, vitamin D, chromium, zinc, potassium, magnesium. And so you can do a full nutritional assessment on your patient at any time, but these are ones that are fairly classic for steroid use. 5-ASA, and that's going to be your medications like mesalamine, mesalazine, and sulfasalazine, a bit of an older formulation. These may be used longer term or shorter term for IBD, and generally an anti-inflammatory. These work really well for a lot of people. And then what you want to consider here is that folate and B12 may become deficient with these, and that quercetin and curcumin have been studied alongside your 5-ASA medications and can be used safely alongside these. So another class of medication that are very commonly used would be these biologic agents, which target specific cytokines or inflammatory factors. So here are a few of the most common you'll see in practice. By far, the most common I will see, and what is often the initial therapy when it comes to biologics, would be TNF-alpha inhibitors. Infliximab is very, very common to see as a first-line agent for biologics. Some clinical considerations here are that there are signs that you can look to see if there will be a good clinical response. So it's been shown that low vitamin D, low bifidobacterium, and low Fecalibacterium are associated with a poorer response to biologic agents. And then higher overall cytokines, so this would be the cyto-DX, if everything is high overall, or if interleukin 8 is high, that can be associated with a lower response to biologics as well. So we can look at our functional testing to see whether there might be a good response here. And then often you may want to use the testing after a person has not responded to a reasonably chosen therapy. Now, there are a couple of other classes of medication that are used less frequently, and you'll see these pop up in practice as well. Let's talk about some of our complementary treatments. Now, I'm not going to talk about everything here, but I am going to talk about some heavy hitters that I think deserve recognition that can target the specific pathophysiology of inflammatory bowel disease beyond just classic anti-inflammatories. So here are a few of what I think should be reasonable treatment targets in every inflammatory bowel disease patient. So we want to assess for malnutrition. This is extremely common and we cannot overlook the importance of nutrition. Inflammation. We want to look at dysfunctional immunology. So not just the inflammatory cascade, but what specific immunology is underlying that. We want to look and cut oxidative stress. We want to repair barrier function and promote healthy mucosal production. We want to work on microbiota imbalances, if there are any, and usually there are. And then we want to look at things like digestive dysfunction. It may not be the biggest player here, but if we have a subset of people that are prone to malnutrition, we want to make sure that their digestive function is optimized. On this slide is a list of the extremely common deficiencies found in our patients with inflammatory bowel disease. I've listed them, I would say, in order of prevalence, vitamin D and iron being the most prevalent deficiencies I see, and iron will be especially deficient in people with a chronic bleed. So it is reasonable to replete any of these nutrients when they're found to be deficient in your patients. Now, specifically, vitamin D is a really heavy hitting nutrient when it comes to inflammatory bowel disease. So this will be found to be deficient in 30 to 40% of IBD cases. And it's not always an outcome of inflammatory bowel disease and poor absorption. So low vitamin D status is implicated in the pathogenesis and onset of both ulcerative colitis and Crohn's. Low vitamin D is associated with more severe disease state and higher relapse rates. So vitamin D can shift towards a more tolerogenic and anti-inflammatory immune system. And I'm listing some specific cytokines here. We don't have time today to go into them, but if you care to screenshot, there are a few cytokines that I'll highlight on different nutraceuticals and botanicals that might be useful in your practice. It's not all inclusive, but there they are. Vitamin D can also promote a healthier microbiota balance and can decrease relapse rates and improve outcomes. So I see that there would be a place for vitamin D in every single inflammatory bowel disease case. You may assess for deficiency first. You may give it empirically at moderate doses, but you are likely to see some improvement in outcomes with the use of vitamin D. Butyrate can be a powerhouse supplement in IBD. So this is one of our short-chain fatty acids that is produced by our obligate anaerobes in the colon and is frequently deficient in IBD, as are the organisms that produce it. So supplementing butyrate can promote immune tolerance. It can be used as an energy source for the cells lining the colon or the colonic epithelium, and it protects the GI barrier function. It can promote mucosal production and can decrease the release of pro-inflammatory cytokines, so can cut through inflammation. And in addition to correcting gut inflammation, it can also cross the blood-brain barrier and correct neuroinflammation and promote the development of new neurons in the brain. It will also upregulate vitamin D receptor activity, making your vitamin D supplementation more effective. Now, one thing about butyrate is that its uptake by the epithelial cells is blocked by hydrogen sulfide gas. So if you have bacteria, a lot of our dysbiotic bacteria will produce hydrogen sulfide gas. And if those are present, you can supplement butyrate all day long, and not the whole amount of it will be able to be used by the cells. So managing your hydrogen sulfide producing dysbiosis will help your butyrate supplementation be more effective. Melatonin. Sleep disturbances are extremely common in inflammatory bowel disease, and correcting sleep can help cut through that inflammation. And so melatonin can be useful for promoting sleep. But beyond a sleep supplement, melatonin is actually a powerful anti-inflammatory, immune regulatory, and free radical scavenging supplement. A lot of melatonin is produced in the GI tract and acts locally. It will decrease our inflammatory cytokine production. It can increase glutathione and our antioxidant capacity, and can affect GI motility. So at certain doses, you'll see an increase in motility. At other doses, you'll see a decrease in motility. So it can be used kind of titrated up depending on the needs of your patient. It'll promote the epithelial barrier function and mucosal production, and will skew towards a more anti-inflammatory microbiota composition. Now, melatonin is something that I frequently use in practice to decrease visceral hypersensitivity. So this can decrease your pain perception and hypersensitivity. So really useful in IBD for a lot of reasons. It can also promote antimicrobial peptide production from the epithelial cells, which will inhibit E. coli. So there are certain strains of E. coli that are classic for IBD, and inhibiting their adherence can improve IBD. So many reasons you can use melatonin here that will be beneficial in your IBD patients. Fish oils. These are strongly anti-inflammatory. A low omega-3 to omega-6 ratio may play a role in IBD development. So fish oils are going to be your omega-3s, whereas your vegetable oils are going to be more your omega-6s. So increasing your omega-3s can be beneficial. We'll see a promotion of healthy microbiota balance, especially your short-chain fatty acid producers, which can benefit the epithelial cell health and be anti-inflammatory. You're going to see an increase in your mucosal function and epithelial cell health. And you may use fish oils alongside other natural therapeutics, and it can make them more effective when you use fish oils. There has been a lot of research into probiotics in IBD, and no absolutely conclusive results on the most beneficial strains, the most beneficial doses, but we do see that probiotics play a role here. So here are the actions of probiotics. On the next slide, I will list some specific strains that have been researched to be beneficial in inflammatory bowel disease. So probiotics can modulate your immune response towards a more tolerogenic immunity. They can strengthen the barrier and mucosal production, increase bacterial diversity or microbial diversity. Probiotics can inhibit pathogenic and opportunistic bacteria, can decrease inflammation, promote tissue healing. So a lot of really beneficial actions here for probiotics. I think they have a place in inflammatory bowel disease. And then the next slide will look at these strains. So here's a short list of specific bacterial strains that have been used with benefit in inflammatory bowel disease. I'll say again that there is no one strain or combination that has shown consistently beneficial results, but overall it seems as if there is a place for probiotics in inflammatory bowel disease. Now, I wanted to have a slide for each of these nutrients. These are plant-derived anti-inflammatory agents, and I think each one is an extreme heavy hitter in IBD. So just because they're all on a slide together, don't mistake that for lack of importance. And what's beautiful here is that when we see cases with dysbiosis and overgrowth dysbiosis, a lot of these anti-inflammatory botanicals are also antimicrobial agents. So you can pick and choose the specific botanicals that have action against specific organisms and also have action against inflammatory cytokines or can decrease inflammatory cytokine production. And here we see a similar category, but actually quite different in botanical action. And you may see a lot of overlap between this list and the previous list. A lot of our botanicals have many, many actions. But the list here is going to be natural plant-based substances that have action in neutralizing our reactive oxygen species. So many slides back when I talked about oxidative stress, these are the nutrients you want to add in your protocols, and you can fine-tune them to each patient that will normalize that reactive oxygen species and neutralize oxidative stress. We also talked about the importance of barrier repair. So as you run a GI map and talk about clinical history with your patient, you will see that very commonly in IBD, there is the need for gut barrier repair. And here are some of the nutrients you may want to consider as part of your protocol that can promote a nice, healthy mucosal barrier. And then beyond the medications I mentioned earlier under the conventional treatment, there are two contenders with some experimental research that can show some benefit in inflammatory bowel disease. So many practitioners are using low-dose naltrexone in our chronic immune-mediated conditions with a lot of success. LDN, for short, has been tested in both Crohn's and colitis in smaller studies, and has shown that it may be safe and effective for achieving both clinical and endoscopic remission, which means symptoms and on scope. You may see a decrease in other prescriptions needed, so they can be used alongside some of the other prescription meds. And what was found in a couple of small studies was that there were less prescriptions used, and it can improve wound healing. What I also see in practice is a decrease in neural inflammation with low-dose naltrexone. So if there is the comorbidity of a mood disorder like anxiety, depression, insomnia, sometimes you'll see improvement when you use low-dose naltrexone. So this is a consideration for part of your protocol if this is part of your practice. Another consideration with some experimental research is metformin, which is frequently used for type 2 diabetes, insulin resistance. So metformin can dampen or decrease inflammatory pathways. It can promote healthy mucosa. It can change your intestinal transit, which in IBD, where there's frequently diarrhea, it can be really beneficial to change that transit and slow it down. Metformin can affect oxidative stress and can support mitochondrial function in those colonocytes, or the cells lining the colon. Metformin can also be used to enrich the Akkermansia levels, which are frequently deficient. This is one of our normal obligate anaerobic bacteria that are frequently deficient in IBD. I would be remiss if I did not at least mention fecal microbiota transplant. So there is some experimental research, but very promising research, using fecal microbiota transplant to improve IBD. Now, this is way outside of the scope of many of our practitioners, including my own, so I'm not here to recommend it, but know that it's out there as an experimental technology for improving this condition. Let's talk nutrition. So many of our clients that work with DSL are nutritionists, dietitians, and work a lot with nutritional interventions. So I want to spend some time here highlighting what can be beneficial and detrimental in IBD. Now, the conventional viewpoint often is that diet has nothing to do with the course of IBD. And I think that is untrue. I'm just going to put it out there. I think that's untrue. Now, when you dig into the research, often you'll have studies looking at specific interventions, and the conclusion at the end of the paper is often not enough research available to make a conclusion. We cannot recommend one specific diet for inflammatory bowel disease, and therefore more research is needed. But more research is needed is not the same thing as diet does not affect this disease state. It is just not making a firm conclusion based on the data presented. And what we know is that there are certain dietary factors that have extreme detrimental effects in IBD. And so avoiding those and promoting a healthier diet can be beneficial. So the power of diet in IBD, as I mentioned, there are no studies that have found the one ideal diet for all IBD sufferers, but we can see that diet will improve symptoms and quality of life. We can see diet occasionally achieving remission and more frequently maintaining remission or promoting remission. We can use diet to ensure nutritional adequacy. And then there's going to be different roles and factors in diet depending on your patient population. So triggering versus ongoing IBD, demographics of your patient, like age, sex, and other demographic factors. So considering everything there when it comes to diet. Now, what has been very well documented is the dietary factors that are risks and protective against the original onset of IBD. Now, if you are a person with current inflammatory bowel disease, this might not be useful, but there's a huge genetic component. So if you have a strong family history of IBD and have not developed IBD, and I don't want to say yet because you may not ever, but the risk factors here are going to be very clear. red meat, simple sugars, high dietary fat, especially skewed towards saturated and omega-6 fats, and then a huge list of things that are protective. So if you have that strong family history and you want to prevent IBD onset, go for the green list. It might be too late for breastfeeding, but if you're having children, it's not too late for breastfeeding if you can manage that. There are some specific IBD-directed diets that I'll talk about so briefly. So medical diets would be exclusive enteral nutrition, which is shown to be really effective, as effective and sometimes more effective than steroids in Crohn's disease, especially in children. And then an extension of EEN, or exclusive enteral nutrition, is the Crohn's disease elimination diet, which is partially EEN and partially a low allergen diet. So it's also been shown to be effective in maintaining remission and very less frequently achieving remission. Now here's a list of diets that have some research of being beneficial in IBD, some more than others. And the take-home message really is that leaning towards a whole foods anti-inflammatory diet with lots of fiber when you're not in remission, the fiber can be detrimental in a flared disease state. It's all about a whole foods diet, basically, and a healthy diet. So doing things like a vegetarian diet is only beneficial if we're using a whole foods approach. And then low FODMAPs diet is not used for any form of remission or decreasing inflammation, but can work for symptom improvement. So reducing things like loose stools, gas, and bloating. Now, I'd like to break this down by food category. So the reds, greens, and yellows. Red is no, green is yes, yellow is, considerations. So when it comes to meat and protein sources, we're avoiding processed meats, deli meats, things like that. We want to reduce our animal protein overall, especially red meat, and we're aiming towards higher quality protein. So not a high protein diet, but a moderate amount of protein. We want to focus on things like legumes, nuts and seeds, fish, eggs, fermented dairy, and then some poultry, things like that can be okay for most people. And then in a clinical sense, we want to make sure that the proteins are well digested. So looking back to the GI-MAP test, we may want to look at the elastase 1, which is our pancreatic enzyme function, making sure that we're fully digesting the proteins that we put into our body. Now, soy protein may aggravate some cases of colitis, and then eggs might be a trigger in ulcerative colitis. So everyone is going to have their individual food sensitivities. I'm not catering to these when I talk about diet. So if you have known food sensitivities, either IgG or otherwise, that can exacerbate an immune response. But here we're going to talk about pretty broad recommendations where, tailor that to your individual patient. Choosing the right fat sources is so important in IBD and any inflammatory condition. So what we want to avoid is going to be our saturated fats or animal-based fats, trans fats like margarine or shortening, anything solid at room temperature that is in any way modified. Omega-6 fats, and here's a list of the vegetable oils that are higher in omega-6 fats. And then we're limiting our milk-based fats, although dairy itself is not a trigger in everybody for IBD, but our milk-based fats like our butters and sour creams and things like that should be limited. In general, we want to go for a lower fat diet to promote remission. We want to use omega-3 fatty acids. We want to get our omega-9 polyunsaturated fatty acids. Some people may benefit from medium-chain triglycerides. Carbohydrates. So what we want to limit is processed sugars, especially high fructose corn syrup rich foods. We want to completely avoid any sweetened beverages, including juices. And I don't mean like freshly juiced fruits and vegetables, but commercially available juices. What we can have is honey, insoluble fiber during remission. So insoluble fiber may be exacerbating flares. And the exception to this is ulcerative colitis that only involves the rectum, where insoluble fiber might be beneficial. We want to have lots of soluble fiber. Some people may be able to handle this during a flare, but then it's been shown that insoluble and soluble fiber are both beneficial to maintain remission and to avoid triggering IBD in the first place. So some people may react to inulin and FOS, so use caution with those and start low, go slow if you choose to use those. Fruits and vegetables. So we want to avoid excessive insoluble fiber during a flare. We want to avoid processed fruits and veggies. When it comes to fruits and veggies, we want to have a lot of these in our diet. So variety and volume are key. We want to get lots of different types of fiber and lots of different polyphenols, which are the colored elements in fruits and vegetables. Cooked vegetables may be easier to tolerate for some, and then there are some common vegetable triggers. So I'll let you look through those. Food additives that should be absolutely avoided. Here's a list here. I'm not going to read them out because that would be so boring, but check your labels. Avoid these completely. And then a few other considerations. Alcohol. And the exception to alcohol is a small amount of red wine if tolerated and if an adult, please. Yeast and yeasted products should be avoided, especially in Crohn's disease where this can trigger disease states. Sulfur-rich foods, canned foods, salt, and chewing gum. Now, what we can have and what's encouraged is a lot of green tea. Coffee seems to be fine for most people, and then some people might find it to be a trigger. Chocolate, fermented foods, and lots of water, especially if a person is flared and experiencing diarrhea. Now, going back to our common deficiencies in inflammatory bowel disease, these are worth repleting either through supplement or through diet. And here's a slide that you can screenshot. This is very readily available information, but some dietary sources of each of these nutrients. And look, it's a healthy, whole foods, plant-based diet. So yes, that was a lot of information. Yes, I went through it all very quickly, but in summary, it is very useful to use advanced lab testing to personalize treatment protocols. Every patient will present differently and will require a different treatment. So you want to monitor those labs at regular intervals, especially the blood and calprotectin if they've been found high. We want to individualize our plan versus using set protocols. And sometimes we call things protocols, but they're actually individualized treatment plans, and we do have to get fine-tuned if we want to get really good results for our patients. There is a role for well-chosen prescription medications in IBD, and I think often a life-saving and life-improving role. And we can work within those conventional bounds by using nutrition and using well-selected supplements. So co-managing IBD cases is really reasonable, and people do need that quality of medical care where they get regular scopes and regular testing. And so refer out as needed and co-manage as needed. And then finally, consult with the DSL clinical team on your most challenging cases. We are here for you. We want you to get really good outcomes. We want your patients to do really well, and we want to be easy to work with. So thank you again so much for taking the time to join us today. If you want to learn more from DSL or from me specifically, and you are a DSL practitioner, you can book your complimentary consults through customer service for any lab you run through us with one of our team members. Our clinical team is amazing. We go through GI maps and our other tests all day, every day, and it is our passion. So let us help you, please. And the rest of the team is also fantastic. I am not the be all and end all for IBD knowledge. Our entire team knows how to interpret the test in the context of many medical conditions, including inflammatory bowel disease. We've got a new learning platform called the DSL Academy, where if you are one of our practitioners and have an account, you can sign up through customer service to access our education and learn more through the DSL Academy. Now, open to anybody is going to be our DSL resource library. So I've done many past webinars. The rest of our team has done a lot of webinars. These are available both through the DSL website or through our YouTube channel, and they're fantastic. Now, to work with me personally, I do one-on-one consulting. I offer second opinions and lab interpretation for anybody outside of British Columbia, Canada. And in addition, I do peer-to-peer consultations with practitioners. So that's it for today's webinar. We will be open to questions submitted through the chat, and I'll be answering those after because I took so much of your precious time, and thank you again for giving us your precious time. We see you and we appreciate you. So have a wonderful day.